challenging problem. Let's talk about atherosclerosis now, shall we? But first, let's talk about cholesterol. Now, remember that LDL cholesterol is low density lipoprotein. And this is the cholesterol form that is transported from the liver to the cells of the body. Okay? Sometimes it collects in the arteries, and we'll talk about how that happens and why that's important, because it causes an increased risk of stroke and MI and vascular disease and things like that. So HDL, we used to call the good cholesterol. Well, we said it was good because the role of HDL is to transport cholesterol from the arteries back to the liver to process and get rid of. We called it reverse cholesterol transport, which sounded like a great thing. So we designed all these studies to say what would happen when we raise the HDL cholesterol. Guess what? Nothing good happens when you raise the HDL cholesterol. Well, it makes sense that we would have thought that, but it also makes sense that it's still just cholesterol. So the fact is, it's in the bloodstream and it's indicative of high cholesterol levels elsewhere in the body. Okay? We don't have a better explanation than that. We just know that it wasn't the right target to prevent events. So don't tell your patients that we want to raise your HDL cholesterol. First of all, it's very hard to do. Exercise, even marathon runners can have an HDL in the 20s. You know, exercise is said to raise your HDL, but like so much that we tell people about exercise, it's just not true. Exercise doesn't help you lose weight. It's never been shown to help you lose weight. And it doesn't raise your HDL appreciably. Now, that being said, I will tell you there is nothing more important for good cardiovascular health than regular exercise. 100% agree that it is the most important thing for your cardiovascular health and your ability to not use assistive devices as you get older. There's no question about that. But don't tell patients it's going to help them lose weight. It just doesn't do that. It's the food you eat that makes you fat. I know, because, of the food I eat. All right, let's talk about triglycerides. Triglycerides are the transport to the fat cells. All right, they transport fats to the fat cells where they get stored as body fat. These are not affected by low cholesterol diets, right? We don't put people with hypertriglyceridemia. I can't say that word. I don't know why I stopped being able to say it. Hypertriglyceridemia. We don't fix hypertriglyceridemia by putting patients on a low-fat diet. It doesn't work. We have to get rid of sugar and alcohol. That is what lowers triglycerides. And by the way, when we lower the triglycerides, we raise the HDL. All right? So maybe all along, it wasn't the HDL that was such a good marker, but maybe it was lowering the triglycerides that was the good marker. I mean, there's been some studies recently that suggest that. The other thing to remember is that when the triglycerides are super high, like more than 1,500, and by the way, normal triglyceride level is under 150, right? When it gets 10 times higher than that, you're at risk for pancreatitis. The pancreas cannot take a joke, right? It never has been able to, whether you're operating and you're told to stay away from the pancreas, or whether we're talking about hypertriglyceridemia, we cannot joke with the pancreas. It will not take a joke. The last thing I want you to know about is apolipoproteins. So HDL and LDL and all that stuff don't just float around on their own. they have to be attached to a carrier protein, and that is the ApoB or ApoA carrier. These are what they're the transport that delivers the LDL particles or the HDL particles to their final destination. There are different subsets of ApoB. There's ApoB48, ApoB100. ApoB100 is the one that we're interested in, and it's the thing that carries LDL, VLDL, and intermediate density lipoproteins. Okay? The ApoA1 carries the HDL particles. The best assessment that we can get of cholesterol transport in the body is the ApoB100. So measuring ApoB is a great thing to do, but we rarely use it clinically because guess what? It really correlates very well with the LDL cholesterol. And that's the target that we have with medicines anyway. So most people just ignore all that stuff, except in the advanced lipid clinics. We just worry about the four basics: total cholesterol, which we can ignore, LDL, HDL, and triglycerides. Now, lipid metabolism, very complicated. This is such a cursory overview that I'm giving you. It's not even funny. Essentially, what happens is when you eat, you take in dietary fat, it gets digested, and it gets picked up in the gut, right? You get these little micelles that convert to triglycerides. Triacylglycerol is another word for triglycerides. And these fatty acids that are attached to the triglyceride molecule get absorbed in the gut as chylomicrons. And these chylomicrons go to the liver, and you may see some in the circulation as well. These chylomicrons then become chylomicron remnants, and the rest of the chylomicron gets converted to VLDL or to intermediate density lipoprotein, or it gets sent out as LDL cholesterol. Okay, and then it goes to the cells of the body, and when the cells have had enough, they send the excess back in the form of HDL. All right, that is a very, very basic understanding of what happens. Remember the exogenous pathway, this is dietary fats, and the endogenous pathway, this is the stuff that involves the liver, okay, is in red. So a couple of important things. Remember that your body has to have cholesterol. You have to have cholesterol. There's no two ways about it. But too much is not good. Now the question is, what's too low? If we put somebody on cholesterol medicine and we lower their LDL cholesterol from 110, and we're trying for a goal of less than 70, and we get down to 40, is that too low? I don't know. Nobody knows. Nobody knows. Now, let me just quickly pull together some of your knowledge from high school and from college. Remember that when we process glucose, we get the first step of converting it to pyruvate, and then we get acetyl coenzyme A, okay, or acetyl coenzyme A, take your pick. A lot of that goes into the Krebs cycle for ATP production. But another arm of the acetyl coenzyme A processing or metabolism goes to produce cholesterol. And the way it happens is that it goes through a whole bunch of steps here where you get acetyl-CoA plus acetyl-CoA, acetyl-CoA. It's a weird thing. But anyway, you go through all these steps, and eventually you get to this step where the acetyl coenzyme A gets combined with the HMG coenzyme A synthase, and that converts to HMG coenzyme A reductase. Does this sound familiar to you? Have you heard of HMG coenzyme A reductase? Maybe not, but I'm sure you've heard of HMG coenzyme A reductase inhibitors. And this turns out to be the step that we are using for with statins to reduce LDL cholesterol. When we use a statin, it is an HMG coenzyme A reductase inhibitor, and we inhibit cholesterol production with that. Now, what increases coenzyme A reductase? Well, one thing that does it is insulin. And this is why the lipids get out of control and the cholesterol gets out of control when somebody is diabetic, because insulin causes an increase in the HMG coenzyme A reductase. Okay? After a whole bunch of steps, HMG coenzyme A reductase goes to cholesterol. And why is cholesterol important? Among other things, it's a component of cell membrane construction. When the cholesterol molecule is part of the cell membrane, it gives some structure to the cell membrane, gives it some firmness, so it's not just a big amoeba-like, jelly-like thing. It gives some structure to the cell membrane and allows for transport of substances through the membrane. It also leads to steroid hormone production. Your body cannot make steroid hormones without cholesterol. So all of your adrenal hormones, cortisol and aldosterone and all the rest, and estrogen and testosterone require cholesterol to make them. The other big important thing is bile salts. So you remember in that step here, when the cholesterol gets back to the liver, it produces bile acids, and those bile acids go into the duodenum and allow for emulsification. You remember what emulsification is, right? If you're in the kitchen and you want to emulsify two liquids, you want to combine them so that the oil doesn't sit on top of the vinegar. Well, one way to do that is to use an emulsifier. And an emulsifier could be bile. Well, you wouldn't want to put bile salts in your salad dressing, but how about mustard? Mustard does the same thing, right? That is a emulsifier that will allow the polar compound and the non-polar compound to mix together. All right. So all that cholesterol stuff finally comes to bear at the cellular level in the vessel when the monocyte becomes a macrophage, and the receptors here take up lipoproteins. Remember, the macrophage is really just a white blood cell that has migrated from the vessel and out into the tissue. And so this now is a macrophage. It picks up these lipoprotein particles and envelops them and absorbs them. And these now become foam cells. They're foam cells. We call them foam cells because they look foamy under a microscope because of all the lipid droplets that they have inside of them. This is the very, very beginning of the atherosclerotic process, these foam cells. So what happens then is the foam cells become they inundate the intima of the vessel wall and start to pick up more lipid, which makes them grow in size. And this now grows the plaque even larger. Now, I want you to notice something here important, and that is the fact that all of this stuff is happening in the intima of the vessel without impinging on the lumen of the vessel. You see that? So here's a normal vessel. This vessel still looks normal, but there's all this plaque that's going on. Here there's a ton of plaque, and we're just now beginning to see the lumen of the vessel be involved. This is very late in the disease, until finally there's some rupture of plaque that happens. All this schmutz from this lipid pool leaks out into the vessel and causes thrombosis, heart attack, dead, end of story. Okay, that is the way that vascular disease works. Now, we have some other tools in the arsenal that decrease the chance of that happening. Your body works with the endothelium of the arteries to release nitric oxide, or NO. And when your normal endothelium releases nitric oxide, it allows it to have better vasomotion. It can expand and contract and move and participate in life. It gets off the couch and it does things useful. All right? That's what nitric oxide allows the endothelium to do. When the endothelium is healthy, it produces nitric oxide, which reduces shear stress and allows for relaxation of the arterioles. That's all good stuff. We want nitric oxide, but it only happens in healthy endothelium. We can give ACE inhibitors that will improve nitric oxide performance and make the endothelial lining healthier. So that's our goal. This back to the atherosclerosis thing again. You can see just another pictorial representation of how this process works. I won't go through it again, but I do want to again reiterate the importance of knowing that the lumen of the artery remains the same size for a prolonged period of time in coronary disease. So let me back you up and tell you how we first discovered this. In the 1950s, they were doing studies. The Bogalusa heart study was done in the 50s, or started in the 50s, where they studied children who were killed in Bogalusa. Is that Alabama? Mississippi? I don't remember. But anyway, Bogalusa. They did posts on children, and they noticed that there were fatty streaks in the coronary arteries, even in these young kids. Soldiers who were killed in Korea, same thing. They could have fatty streaks in their arteries, and yet these patients hadn't developed coronary artery disease in a clinical sense yet. Well, fast forward to around 2000, the late 90s, a guy named Steve Nissen, who's a cardiologist, I think he's still at Cleveland Clinic. He may have moved on by now, but sort of world famous cardiologist, did this study where they took donor hearts, right? So these are predominantly 20-somethings who had brain death and they were going to harvest their organs. Well, 20-year-old kid you wouldn't think has coronary disease, right? Well, in fact, they did coronary angiography, and look how nice and smooth this vessel is. It just looks beautiful, right? I mean, these are gorgeous coronaries. You would all want to have coronaries that look like this as well. And where this arrow is where they put an intravascular ultrasound catheter. And look what they found. There's this huge lipid plaque that occurs right here. Totally normal, rounded, normal coronary artery that shows up very nicely on the angiography, but this plaque is in the wall of the vessel. It doesn't show up on angiography yet, but it's clearly there, and it is ugly. So even in 20-year-olds, we have seen the development of this coronary artery disease that doesn't become clinically evident for another 20, 30, 40 years. But it starts early. And the take-home message of that is that the cholesterol plaque, we used to think, would just continue to impinge on the artery until it finally closed. We know now that this plaque can develop and be present for 20, 30, 40 years or more before it ever causes any narrowing of the artery. So listen to this. When we do a catheterization and we tell a patient they have clean coronary arteries, that is not the message the patient should hear. If they have risk factors and we see no evidence of blockage on the coronary artery, on the coronary angiogram, we should tell them that they still could have blockages. We have to make sure that you're managing all of your risk factors as best as you can. Keep your LDL low, keep your blood pressure under control, don't get diabetes, don't get older, change your parent. Well, you can't do those things, but you know what I mean. We want to still manage their risk factors. Don't tell them everything's fine, you don't have coronary disease. Tell them everything's fine, you don't have any flow limiting blockages that would cause chest pain, but we still want you to manage your risk factors aggressively.